I'm very happy this evening to welcome Dr. Max Gilbane. He is an audiologist who trained at Vanderbilt University. He has experience in various activities, private practice, university hospitals, and the VA. Most recently, he completed a rotation at the Jefferson Balance and Hearing Center in Philadelphia, and now works in, sorry, I've lost the name of the organization, ENT and Allergy of Delaware. Sorry, Max. At any rate, you can put questions to Max in the chat, or you can wait until after he completes his talk and ask the questions directly. So at this point, thank you very much and welcome Max Gilbane.
Thank you guys very much for having me. I'm going to go ahead and attempt to share the screen here. And I'm going to assume that everything is working well and that you guys can see me and hear me. And if that is not the case, please let me know. So here comes the screen share. All right. Is that coming through for everybody?
Yes.
Wonderful.
Yes.
All right. So as Hope mentioned, I'm Dr. Max Gilbane, but please feel free to call me Max. I'm a clinical audiologist down in Delaware, but I do live here in Philly. So I really appreciate the opportunity to talk to members of the local community. I myself live here in Germantown near Ultimo Coffee. And what I wanted to do tonight is give an overview of what I see as the relevant points of navigating hearing healthcare, because it's a very confusing system. So the structure of the talk will follow this basic outline. I'll first go over the anatomy of how we hear and what can go wrong. Then we'll go into the assessment of hearing and what a hearing test actually looks like. Then we'll move into hearing aids, what we can do to help get you hearing better. And I'll finish up with some questions that I commonly get. However, I've intended the talk to take just a portion of the time allotted so that we will have some time for Q&A afterwards. A few disclaimers here. I have no financial relationship to any of the hearing aid companies. There will be one point in the talk when I'll use graphics from a manufacturer to illustrate different styles of hearing aids. Nothing in this talk is meant to be an endorsement in any way. It's also not going to be exhaustive. So there's simply not time to cover cochlear implants, insurance coverage, vertigo, but I'm happy to answer any questions to the best of my ability. And the talk is also not meant to replace a visit with your hearing healthcare professional. One more disclaimer I should add that's not on the screen is that my wife and I have an 11-week-old baby who's about 2 rooms behind me. And hopefully baby Milo's gonna stay nice and quiet, but I'd like to apologize in advance if he has any contributions to the talk. Hopefully they'll be kept to a minimum. And thank you guys again so much for joining me. So let's jump right in. How do we hear and what goes wrong? This is an illustration by German anatomist Max Brodel that goes over some of the anatomy here, and it's way more detailed than I expect anyone to really care for, but it to me is a really beautiful representation of the anatomy of the ear. And perhaps I can point out a few relevant features here. Now, actually, I should ask, are you guys able to see my cursor here or not? And if not, it's no problem.
Yeah.
But
Yes,
I can see it.
you can. Wonderful. So what I'm circling here with my cursor, and don't worry if you can't, but what I'm circling here with my cursor is one of 3 anatomical divisions of the ear. So the ear can be broken down into outer, middle, and inner. And the outer ear includes the ear canal, going, of course, to the outside world, and the ear drum, which we call the tympanic membrane. Then there's the middle ear, which includes the little bones, malleus, incus, and stapes. And we'll go over those in the next slide. Lastly, there's the inner ear, which has a portion pertaining to hearing, and it also has some structures pertaining to balance and our sense of orienting ourselves in space. So let's go through these systems.
Max, I'm going to have to mute everybody again
and then you'll have to unmute yourself
Sure.
because people entered
No problem.
late.
No
Okay.
problem.
All right.
All right.
Thanks.
So we've got our outer, middle, and inner ear. And let's first talk about the outer and middle ear. They basically have two purposes. They conduct vibrations, sound, to the cochlea, which is part of the inner ear, and they also increase the strength of those vibrations. So the outer and middle ear act a little bit like a funnel, bringing sound to the eardrum. And then in this graphic here, you can see that the little bones, also called the ossicles, act as pistons with a bit of a lever mechanism and serve to amplify the force of those vibrations so that by the time the vibrations reach the cochlea or the inner ear, they have more strength to them. There are a number of problems that can arise in this pathway. So you could have an obstruction in your ear canal. Often that's going to be wax. You could have problems with your eardrum itself, maybe a hole from accidentally using a Q-tip too forcefully, maybe a hole from an infection in the middle ear. You could also have damage to the bones in the middle ear. Perhaps some of you know someone with a disorder called otosclerosis, where bone ends up building up over the stapes and covering it, preventing it from functioning effectively. Any of these types of problems with the outer or middle ear are referred to as causing a conductive hearing loss, which makes sense, right? We can't conduct the sound to the inner ear properly. As far as the inner ear goes, we have this beautiful scanning electron micrograph photo of the cochlea. And the purpose of the cochlea, which again is just a portion of the inner ear, is to convert vibrations into nerve signals. Now, the ways it does that are beyond the scope of this talk, although I'm happy to nerd out about them to anybody who cares. But there are sort of two types of problems you could have here. You could have damage to the hair cells in the cochlea. So you've probably all heard about hair cells, and you probably know this, but they have nothing to do with the hairs on your head. It's really a special type of receptor cell that has a little hair-like projection sticking out of it, thus the name. And those little hair-like projections can have all sorts of damage. It's actually a very fragile organ altogether. Noise, aging, certain medications, especially if you've had chemotherapy or strong systemic antibiotics, all of these things can affect the hair cells. You could also have problems with the auditory nerve. Think of that as the wire that connects the inner ear to the brain and other central nervous system structures. So the most common problem there might be something like an acoustic neuroma, which is a type of benign tumor. But again, we basically have problems either with the sense organ, the cochlea, or the nerve. So because there's sensory problems and nervous problems, we call this a sensory neural hearing loss. You could, of course, have both. You could have a sensory neural hearing loss and a conductive hearing loss, in which case you would be considered to have a mixed hearing loss. Okay, so let's talk about how to actually assess somebody's hearing. And I always like to start with a why. So why bother test your hearing? Well, there's a few reasons. One is to rule out any medical issues. So the treatment is going to be very different for a tumor than an infected middle ear. And certainly, best case scenario is that we just find an ear full of wax, which we remove, and then it, restores a degree of hearing. We also want to learn about the status of each part of the system. So that's going to help determine the treatment course, but it's also going to inform realistic expectations. So for instance, if somebody has problems with the nerve leading up to their brain, or perhaps auditory centers in the brain as well, it's entirely possible that a hearing aid isn't going to restore function to quite the level they were hoping for. And I'll talk about this a little bit more in a few slides, but there are different types of hearing loss, and they may inform different types of expectations for different patients. It will also obviously guide the programming of hearing aids. So testing someone's hearing helps create an initial prescription, if you will, which should not be the end point of programming hearing aids, but is a useful starting point. Okay, So what are the parts of that hearing test? Well, otoscopy, as you might be able to break apart from the name, is simply the act of looking in the ear, which is typically the first thing that we'll do. Tympanometry may evoke memories of my having said that the eardrum is called the tympanic membrane. So tympanometry is a series of measurements of the eardrum. And this is a test that is kind of infamous for people forgetting that they've had it done. So I'll do it to someone and they say, oh, I've never had this. But if you've ever had a hearing test and they put a little pressure in your ear just for a moment, and maybe you heard a low humming sound, that's tympanometry. And really we're looking for three things. I want to see if there's a hole in your eardrum, if there's any fluid behind the eardrum that's preventing it from moving the way it normally should. And I want to see if there's a difference in the pressure in the outside room versus in the ear. So for instance, when you're on an airplane and your ears pop, it's an equalization of the pressure happening. So we can measure any of those little differences. That's tympanometry. Then you have audiometry, the measurement of hearing itself, which itself has different components. For the tones or beeps, we like to measure those two ways. There is air conducted sound, which is what you normally think of when you're listening through headphones or through speakers right now. My voice is vibrating a microphone, and that microphone is digitizing the signal, sending it to your speakers, which are then vibrating air to be passed through your ear. But we can take some shortcuts there. And when we're doing the hearing test, I can put a bone oscillator on the back of your head, which will just vibrate the bones of your skull directly and send the signal straight to the cochlea. Why would we do that? Well, if somebody has a problem with their outer or middle ear, this allows us to see how the cochlea, how the nerve and the sense organ are doing, independent of any problems farther out in the system. We're also going to test speech. Testing quiet speech serves as kind of a way to double check that everything else is matching up. And testing loud speech or normal levels of speech really is a very helpful way of seeing how people can perform under optimal circumstances. So if you're in a sound booth and you're listening to a recording of some words with no background present, it can be very useful to see how you do. Many people have a significant hearing loss, but under those circumstances, they'll have a word recognition score of 100%, meaning they were able to repeat all the words back correctly. Others might have a more mild or moderate hearing loss, but they do very poorly on the word recognition score. And that again comes back to realistic expectations, because hearing aids are not going to change your ultimate word recognition score. They'll just help you realize the potential that it implies. And I can happily answer any questions about that for those who want to go into more detail. So ultimately, you'll get something that looks kind of like this. If you ask for a copy, or you're someone who likes to look at graphs, this is the audiogram. And what we're looking at is a measurement of the sensitivity of your ears to different sounds. Those sounds are arranged by pitch or frequency. So on the x-axis, we have different frequencies here. You can see it's on a logarithmic scale. So low frequencies are on the left side, high frequencies are on the right side. And the y-axis tells us how loud a sound had to be for this example person to hear them. And everything going down, by the way, is worse. So the louder a sound had to be, the farther down the graph it is. Everything in red is for the right ear. Everything in blue is for the left ear. So let's take some examples here. So if we look, for instance, at 2000 hertz, we can say that both the right and the left ear needed the sound to be about 40 decibels in order to hear it. So every one of these points says, how loud does that pitch have to be for you to hear it? And when I look at this, there's a few things that immediately jump out to me. Number one is, this is what I would consider to be a generally symmetric hearing loss. There's not a big difference between the right and the left ear. We consider test-retest variability to be about 10 decibels. So there's not a huge consistent pattern of one ear being worse than the other. The other thing that we see is that this is a very common pattern of what we would call a high frequency hearing loss. So this person has worse hearing denoted by lower on the graph, for higher pitch sounds on the right than they do for lower pitch sounds. So the cutoff for normal, by the way, is usually 20 or 25 decibels. So at the border between 70 and 80, this person would probably be considered to have a severe high frequency hearing loss. Now, someone with this type of audiogram will come into my clinic and they'll say, I can hear, but I can't understand, or it sounds like everybody's mumbling. And the reason for that is certain speech sounds will lie here in this soft, high frequency range. A lot of consonants, for instance, are soft, high frequency sounds. The difference between search and church, or shoes and choose. Two words can sound very, very similar and differ just in these subtle ways. So if I had to make a gross oversimplification, I'd say that low frequencies give us our sense of volume and high frequencies give us our sense of clarity. So for someone with a high frequency hearing loss, like I would imagine probably some of you have, because it's the most common type, what you experience first is a loss of clarity. And that also can fuel people, it can fuel one's hesitation to actually do something, because they say, no, I hear okay. When someone knocks on the door, I hear just fine. When the lawnmower is going outside, I hear it no problem. But you're just missing the punchlines to jokes, and you're having to ask people to repeat themselves. So that's really the common presentation here. Okay, so what can you take home from that? When should you really get your hearing tested? Well, if you are having trouble hearing, you should get your hearing tested. If you think that your hearing has changed, maybe it's been a few years since your last test, great idea to have a new hearing test. If you have any symptoms that might be related to other problems in your ear, vertigo, by which I mean, either room spinning or a sensation of motion. I'm not referring here generally to lightheadedness. I'm really talking about a sensation of motion. Or if you have pressure or pain, or obviously if you have drainage from your ears, you certainly should get checked out. And if you're going to remember one thing from this section of the talk, it's that a sudden hearing loss is a time-sensitive medical emergency. Sudden hearing loss is a time-sensitive medical emergency. And the reason is, best case scenario, it's wax. But if it's actually a real sudden hearing loss, the treatment for that is usually prompt administration of steroids by an ENT, and the likelihood of that helping to restore any of your hearing falls off very dramatically with the amount of time it took to get that treatment. So the first couple hours, first couple days, if they say I'll see you tomorrow, no problem. But don't wait a week or two and see how your hearing is. Go see someone if you have a sudden change in hearing. Especially, this will often happen just in one ear. Okay, so hearing aids. All right, the main goal of hearing aids is to maximize audibility for speech. So that's their bread and butter. We want you to be able to hear speech. There are some secondary goals, however. It's nice if they can help resolve one speaker from a noisy background. It's nice if they can help you pick up on sounds in your environment, like birds, or localize sounds, meaning tell where they're coming from. Obviously, that has safety implications when it comes to cars, and practical implications when it comes to people calling you from different rooms of your house. Perception of music is a good example, if I do say so myself, of a secondary goal, because hearing aids, again, are designed for speech. If you can hear music better, that's wonderful. I love to work with patients who love music. I love music myself, but it's never going to be the primary purpose of the hearing aid. And so, at the risk of getting ahead of myself a little, hearing aids these days, as you guys might know, will often have Bluetooth capabilities. And that can either allow you to use an app on your phone to change the volume, or even stream audio like phone calls. Streaming a phone call to your hearing aids can be fantastically helpful, because now you're hearing the sound in both sides instead of just one. However, streaming music through hearing aids doesn't usually sound quite as good as using a dedicated pair of headphones. And some of the reasons are obvious. I mean, you know, this pair of headphones would not be accepted by individuals as a pair of hearing aids simply because they're so big and clunky. And so there are certain trade-offs that companies make when designing these things. So I don't want to belabor the point too much. We'll come back to that if anyone's interested. Okay. There's two things I like to tell every hearing aid patient that comes into my office. And one of them is that hearing aids are not perfect. I don't mean this to be a downer, but if you are watching British television shows, they will not translate the British English into American English. I recommend using closed captioning. Masks are still going to block visual cues and muffle people's voices. If you go to a grocery store and they've got a mask on and they're behind one of those acrylic walls, well, you know, that is really going to block a lot of that sound energy. So again, realistic expectations. Furthermore, in a noisy room, it can be tough. One of the most common complaints I get, or maybe I don't get them as much because I tell everybody this at the front, but if you go to a restaurant, especially a busy restaurant on a crowded night, I mean, it's really tough. And I would bet that probably everyone on this call has struggled to hear in a restaurant at some point, even if your hearing is perfect. Noisy rooms are just challenging. And I mentioned that hearing aids are good at telling speech from noise, or at least they try to be, but they're not always perfect at telling speech from speech. So if you're in a room of tons of people talking, it's challenging for the hearing aids to figure out who you're trying to pay attention to. The other thing I like to tell people is that it's a process. So it takes several visits, and it's an investment not just of money, but of time. The selection and programming and follow-up will take several visits, but that's actually usually a good thing because most of what those visits include is troubleshooting issues that you're having. So my least favorite experience for someone to have, and what really galls me when I hear about it, is people who get hearing aids, spend all this money, and then put them in a drawer. What a waste of time and money. I think everyone deserves better than that. And usually when I ask people, you know, this might be someone who put their hearing aids in a drawer and then, I don't know, 7 years later, they're seeing me because they really feel like they have a problem now. And I ask them, well, what was wrong with your hearing aids? And they say, oh, you know, it didn't fit right, or it whistled, or it was too loud. It wasn't loud enough. It didn't help. All of these issues can be solved. Now, not everything can be made perfect, you know, see the left half of this slide, but almost everything can be made better. And what I do most of the day, every day, is just troubleshoot this type of problem. If someone's getting feedback or whistling, it might be because they're not putting the hearing aid in their ear right. It might be a programming issue. It might be that their ear's full of wax. But we're not going to know necessarily that you're experiencing these problems if you don't tell us about them. So if any of you have hearing aids and are having issues, I would, you know, urge you, talk to your audiologist and make sure that, you know, they're doing everything they can to resolve these issues. And as long as you know that they're not perfect and that it's a process, I think you'll have a much better experience because you're going to go into it knowing what to expect. Okay. A little intermission for some fizzy water there. Now, what are the two types of decisions people are making when they're looking at hearing aids? Well, one of them is the different styles of hearing aids. You could think of that as the different shapes and sizes. And those generally serve different purposes, hearing-wise and logistically. Then there are the different levels of technology, which is largely what determines cost. Now, at my clinic and many clinics, these are two separate conversations, meaning I'm going to show you some styles here, and they all cost the same, which is to say the next slide is going to feature a bunch of different hearing aids, and people say, how much does that one cost? How much does that one cost? No, these are just cases into which we can put different chips, and those chips, that electronic system, is what determines the cost. So let's start with the styles, because I think it's a little bit more straightforward. Okay, this is where I warned you. This is straight out of a manufacturer's website. A few caveats here. Again, this is not me endorsing Phonak, which is the hearing aid manufacturer. As a matter of fact, these models are from a couple years ago, so I wouldn't even recommend these models today. But I think it's a useful graphic. Now, you can see here they've sorted the hearing aid styles into two basic categories. We have to get something in your ear canal, so we can either put the whole thing in your ear, or we can put it partly in the ear and partly behind the ear. So generally speaking, I mentioned that this is just going to have logistical implications and sound implications. Different hearing aids are going to suit different people. For instance, these hearing aids over here on the right, top right, for those of you who maybe may not be able to see the cursor, these are, it's an older style of hearing aids. Sure, you guys might have seen folks with hearing aids like these 20 or 30 years ago, but they still make them like this, and for good reason. These hearing aids are the easiest to insert, and so for individuals with poor dexterity, maybe they have arthritis or neuropathy, carpal tunnel, this is something I'm looking at. This is also something I'm looking at a lot these days because of COVID. You know, with the masks coming on and off, I was actually talking with Hope and Myra about this before this talk. When people take the masks off their head, that's where you run into problems, because before COVID, about 80% of the market share was this: receiver in the canal. Now, receiver is just our word for speaker. So speaker in the canal, and the rest of this thing is just behind this guy's ear here. It's fantastic. It works great for a lot of people. There's a number of advantages. You keep the ear canal very open, so it doesn't feel like there's much in your ear. It looks really nice. You can have a pretty discreet profile, and you don't have a big old thing like this in there. But then you go to take off your mask, and it's going to snag, and it's going to pull that little piece, and that's where you run into problems. So this is a very individual decision, and I'm not going to say here's the best style. It really depends on the person, and this is the type of thing I talk about when people come in and have discussions with me. For instance, these powerful behind the ear hearing aids are going to be for someone with a severe or profound hearing loss, or for children who might get hit in the side of the head with a soccer ball, and having a big plastic mold is better than having a more fragile thing. I'll also just briefly touch on some of the downsides of these real teeny tiny ones. Everybody says, oh, I want the little invisible one. And there are downsides whenever you miniaturize something. The most concrete downsides that I can think of for these ones are that, well, number one, these hearing aids mostly run on little disposable batteries. And basically everything from this on, so all of the bottom hearing aids and then the in the canal and full shell hearing aids, those are all rechargeable. So if you're buying a hearing aid in 2022, or frankly even last year, unless you have a good reason not to, you should get a rechargeable hearing aid, because the batteries are tiny on these older hearing aids. They don't last very long, and it's a pain in the butt to change them. And I bet some of you guys have had to deal with this. So that's number one. The other thing is these smaller ones are not necessarily going to have the same degree of technological flexibility. So they might not have that Bluetooth connection that I mentioned earlier. Okay, so what you probably are left with now is this sort of confusing mess of styles, and that's okay. It's different for different people. Talk to your audiologist. These days I fit a lot of these, but I used to fit a lot of these. It comes and goes depending on the patient's needs. So let's talk about that other factor, the level of technology. There's some things that should be included no matter what. So you should have visits and programming included. This is called the bundled service model, where you pay one flat rate and you get your hearing aids and you also get your visits. Some places do what's called unbundling, where the hearing aids should be considerably less expensive, but then you're going to pay more for services. So it's okay to do that. Just know which way you're going. For instance, if you're going somewhere with a bundled sales model, which most places have, part of what you're paying for is those visits. And so again, you're leaving benefit on the table if you don't take advantage of those visits. So talk to your audiologist if there are problems, and read whatever you sign when you're getting the hearing aids, because likely you're having some number of visits included in that. You're also going to have a warranty, which will have a repair clause, usually pretty simple and no questions asked. And then there'll be a loss and damage clause, which is a little bit more complicated. Loss coverage for hearing aids typically has a deductible of several $100s, but is cheaper than replacing the whole hearing aid with a new one. So that's something to be aware of. And there's always going to be some degree of trial period, okay? The length of the trial period varies depending on the state. I've seen, I think 1 to 2 months is about the range. And there are some things that you might be charged extra for. So you may be charged extra for a charger or for custom earpieces or accessories like a remote microphone. This varies clinic to clinic. So my practice includes chargers and includes custom earpieces, but I would never assume anything. Always check. Now, what then, if all these things are in common, what then differentiates higher end or lower end, cheaper or more expensive hearing aids? There's basically a spectrum of cost. And at the top of the line, I'm going to give you guys some example numbers here. These are not the prices from my clinic. I've worked in a number of different settings, and I'd say these are about averages. At the top of the line, you're probably looking at hearing aids that run somewhere around $7,000 per pair. This is assuming a bundled model, so assuming this includes everything. And this is the highest end device typically available. Part of the reason I'm including prices here is because I don't want to scare you guys away, but I want you to know that if you go to somewhere like Miracle Ear and they tell you that there are hearing aids that cost $10,000, or you read an article about hearing aids that cost $14,000, I would say you should really raise your eyebrow if you're being sold something more than $7,000-ish at this point. It varies place to place. I'm sure, cost of living will affect this somewhat, but 7,000 or thereabouts is about as much as I would expect you to be reasonably charged, unless there's something really unusual going on. And what's special about these devices is the higher end hearing aids are going to be very good at analyzing the environment you're in and dealing with some of the complex situations that may arise. So let me give you some examples. If I'm having a one-on-one conversation with you, it's going to be very easy to understand me in a quiet room. But if we're in a cafe, or we are, at Weaver's Way Co-op, or we're on a plane, or in the back of a car, there's all these different situations where, again, there might be other people talking, there might be the noise of some machinery, there might be music, and higher end hearing aids are going to have features that help minimize wind noise. They're going to have features that are going to help music sound better. And in general, they'll be more automatic. At the other end of the spectrum, you're looking down to about $1,500 a pair, and they'll work very well in quiet environments, but might have challenges with some of those other environments. So let's say, for instance, I have a patient who is mostly at home, and they spend a lot of their time reading and playing Sudoku or Wordle. And then, once a week, they have a quiet one-on-one lunch with their friend. That person certainly deserves to hear as well as anybody else, but they might be able to save some money on their hearing aids by not paying for some of the features that another person might want. So that person could probably get some benefit from, a more affordable pair, relatively speaking. And there's typically several tiers between these. So maybe there's a $3,000 and a $4,000 pair as well. So it really varies person to person. Someone who's, working as a flight attendant, or someone who goes to bingo night all the time and goes out to dinner all the time, is going to have different needs than somebody who's mostly in quiet. All right. Now, that is the general picture of typical hearing aids. And bear with me, because I'm sorry, but I'm about to make it a little bit more complicated. Okay, so you guys may have heard about over-the-counter hearing aids, or direct-to-consumer hearing aids, or any of these other things. Let's go column by column and talk about different types of, let's call them service delivery models, different types of products for people with hearing loss. So in the leftmost column, we have personal sound amplifiers, or PSAPs. This is what you see by the counter at Rite Aid for $100. This is sometimes what you see maybe ads for in the newspaper or television. Anything that just costs a few $100 is probably a PSAP. And these are for individuals with normal hearing. But you wouldn't think that looking at the packaging or the marketing. They are legally required to only be for people with no hearing loss. And you might say, well, why on earth would someone get them? Well, maybe you're a birder who wants to hear the rustling of some bird in the bushes, or maybe you're someone with normal hearing who just needs a little extra help. These devices are at least ostensibly for those populations. They're not for people with any hearing loss. They are cheap, but you get what you pay for. Then the next step up is the direct to consumer hearing aids. So companies might include Eargo or Lively. I would steer clear of Eargo. I think they had a scandal involving some fraud. You do your own due diligence there. But Lively, for instance, they sell hearing aids directly to patients. And the way it works is you have to have a mild to moderate hearing loss, and they're less expensive because, again, you're it's a little bit more of an unbundled model. But what happens is you do some sort of consultation with them and you get your hearing aids. And actually, I don't even know if there's a consultation, but you get your hearing aids and all of your care is via telehealth. So that's a good thing and a bad thing. It's a good thing for folks who live in remote communities or folks for whom cost is a significant barrier. The bad side is a lot of the things that I do on a day-to-day basis are not things that are very easy to do via telehealth. So teaching someone how to put a hearing aid in their ear is challenging enough in person, and I can only imagine trying to do it over Zoom or looking in someone's ear canal, or just having a conversation about different listening environments. And there's just all sorts of things where telehealth falls short. But I'd say this is in the category of, there's a time and a place for everything. So I don't want to knock it as a category. I would just say, again, do your due diligence. Then we've got then we've got self-fitting hearing aids, which so far, to my knowledge, is only the Bose device. And that hearing aid uses a proprietary algorithm to sort of do a little hearing test on you, and then it fits itself. And it's also for individuals with mild to moderate hearing loss. They're cheap and they're good hearing aids. However, they're not going to have Bluetooth, they're not rechargeable, and there's no in-person visits. And so, again, I would say you get what you pay for. This is actually probably a pretty good value for individuals with mild to moderate hearing loss if you truly have no other needs and you're someone who can be completely self-sufficient and is not looking for guidance. Okay, over-the-counter hearing aids. I'll take another sip because this will be a big one. All right, so up until now, up until present day, the world of everything on the screen, pretty much, except for traditional hearing aids, has been very, very unregulated. It is the Wild West out there. There are no over-the-counter hearing aids yet, but there are plenty of companies marketing themselves as having the first over-the-counter hearing aid. There are plenty of people, consumer advocacy groups, writing to the FDA saying, what are you guys doing? Please send some cease and desist letters because there's all this fraudulent stuff going on. And there's been very, very little done to stop the sort of huge unregulated marketplace from just kind of abusing its position. But the purpose of the Over-the-Counter Hearing Aid Act was to carve out a space for devices that would be legitimate, helpful hearing aids for individuals with a perceived mild to moderate hearing loss. And here's a little legal background on this. In 2017, the FDA Reauthorization Act directed the FDA to create a category of over-the-counter hearing aids. And if I recall correctly, they said, please make this category by 2020. And then with the pandemic and everything, 2020 came and went, and then an executive order happened, and they said, okay, now please do it now. And long story short, a comment period just ended. They put out some proposed rules in October, and they just finished a comment period on that. So the FDA is kind of now figuring out what to do with all these comments and figuring out their category of the rules for the devices. But probably by the end of this year, there will be a vast world of over-the-counter hearing aids. You'll probably see more devices from Bose. I would not be surprised to see players like Sony or Apple or LG all the big names in consumer electronics, as well perhaps as some of the typical hearing aid companies, are going to want to get in on this space. You'll probably see a lot of devices in the like $500 to $1,200 range. And again, they're all for individuals with a perceived mild to moderate hearing loss. So there's a problem there. Every day, I see people who say, I hear just fine. And I do their hearing test because their wife made them come in and they have a severe hearing loss. Or I see people who say, I have a severe hearing loss, and I do their test and their hearing loss is mild. And the point is, people are not very good at estimating their own abilities to hear. And I think I saw some suggestive nods between couples there. So people are not very good at estimating this, but it certainly will be helpful for a lot of people. My only fear is that some people with a more severe hearing loss will try this. They'll say hearing aids don't work. I knew it. They'll say this was a waste of money. They'll put them in a drawer and they'll never do anything about it. However, I think those will hopefully be a minority. The optimist in me says only 1 in 5 people right now, this is true, only 1 in 5 adults that have an aidable hearing loss or a need for a hearing aid actually wears one. And cost is certainly not the only barrier. In fact, other countries where hearing aids are free don't have much higher adoption rates. But whatever it takes to penetrate the market and get people hearing better is good by me, because as we'll talk about in a little bit, there are implications for your cognitive health. And I just want people to hear better. It's, you know, why I do what I do. So that's my spiel on that. And let's do a little take-home messages on this section before we move on to some FAQs. Okay, so find an audiologist that you trust. It should be someone who's using evidence-based best practices. And I don't expect you guys to know what all those best practices are. So one kind of shortcut here is, if you ask them, do they perform real ear verification? And when you get your hearing aids, ask them to do real ear verification. That's a good kind of litmus test. Real ear verification is a process in which microphones are inserted deep into the ear canal along with the hearing aids, and we measure the actual output of the hearing aids at the time of the fitting. And I could go on and on about why it's useful, but it's one of those things that's an extra step for the audiologist and makes their life a little bit more work, but it's very beneficial for the patient. And so if the audiologist is skipping that step, I would find someone who doesn't. Our job is to help you navigate all of the complexity that I've been talking about tonight. And I hope that I haven't made you guys more befuddled about everything. But if I have, find an audiologist who can talk through it at an individual level. Okay. And remember that it's a process. Don't put your hearing aids in the drawer. Come let us know. All right. So what are some of the most common, frequently asked questions? I'm gonna throw a couple of these out there because I bet I'll save a couple of you the trouble. Tinnitus. I have ringing in my ears. Is that normal? Yes and no. It's at the very least, it's very common. About 15% of people, maybe up to 25% of people experience tinnitus. It's not always ringing. Sometimes it's a humming or buzzing, rushing, roaring. And for the vast majority of people, it's non-bothersome. It's a sound that they've learned to live with. It's neither good nor bad. It's just a sound. Not usually a sign for concern. If you're hearing your heartbeat in your ear, or if it's just on one ear, you should get a hearing test. If you guys want to hear more about tinnitus, I'm happy to talk your ear off about that. No pun intended. It's sort of a area that I'm very passionate about. And so just in the interest of time, I'm going to sort of leave it there for now, but I'll go deeper into it if you guys have questions. And I'll just mention, in terms of, is there anything that can be done about it? Talk to your audiologist. It is often chronic, the sound component, but our reaction to that sound can often be effectively managed. And there's decent evidence to suggest that hearing aids help in this department. Also, for folks who have chronic, bothersome tinnitus, especially those for whom it interferes with their activities of daily living, like sleep, cognitive behavioral therapy can actually be very beneficial. So again, when we get to questions in a little bit, I'm happy to field any of those. Okay, hearing and cognition. This is a hot topic. There's so many headlines about this. I heard hearing loss causes dementia. Is that true? Well, there is an association between untreated hearing loss and cognitive decline. So there's definitely a correlation. In fact, untreated hearing loss may be the single largest modifiable risk factor for cognitive decline. They are still trying to figure out if hearing aids can effectively stall or reverse this process. Here is a graphic from the Lancet Commission into Dementia Prevention. And what it shows here are the risk factors for developing cognitive decline later in life. Life moves like a river through this graph, going from the top around the bend down to the bottom, with early life, midlife, and late life risk factors. You'll see that the largest bubble, everything in color, by the way, is a potentially modifiable risk factor. The largest bubble is hearing loss, accounting for 8% of the potentially modifiable risk. You'll also notice that social isolation is another 4%, and you can imagine that hearing might have a relationship there. And of course, many of these are interrelated. I mean, social isolation and depression, it can get hard to tease these things apart. There are basically 3 theories as to why this link might exist. One of them is that it all comes down to social isolation. Hearing loss makes you have a hard time socializing, so you don't do it as much. One of them is that it's sort of a pure kind of use it or lose it type of loss of stimulation. The brain is getting less input from the ears, and so there's some deficits as a result. And then the third, and in my opinion, most compelling theory, I mean, usually the answer is it's a combination of all of them, so that's probably still true. But the third theory, it pertains to what's called cognitive load. So when you're hearing, you're not hearing everything perfectly. You're hearing most of what I say, and then there's little bits and pieces that you don't get, and your brain is sort of filling in those gaps. But as you have more and more hearing loss, there are more gaps to fill in, and your brain has to work harder to do that filling in. So it's possible that that increased listening effort, that increased listening fatigue over the course of the lifespan might be taking up precious resources from, say, consolidating memory or executive function. So that's hearing and cognition in a nutshell. Again, there's a correlation there. We don't yet know exactly what role hearing aids may play. We just know that untreated hearing loss is the largest potentially modifiable risk factor. This is all at a population level, though. So if you have some hearing loss, I don't want you to lose any sleep over this. These are trends that come out if you look at thousands and thousands of people. All right, for hearing aids, how long do they last? I tell people on average 5 to 7 years. Just like your car, some of you probably have a Honda Civic with 250,000 miles on it, and some of you probably get a new car every 3 years. People are the same with hearing aids, okay? This being Mount Airy, I'm sure it's a lot more of the former group. I know a lot of folks like to take good care of their stuff, and that's awesome. So your hearing aids might last longer, but just like your car, towards the end of their life, there might be more repairs needed. And this is the best kind of average I can give you. They are electronic devices, so they do fail over time. And it's a pretty hostile environment being in your ear not 24/7, but 12/7. And things like sweat, we live in a very humid climate, and sweat is very salty. Electronics don't like salt. So these are all things that contribute to the wear and tear. And with all the choices, how do I pick one? Talk to your audiologist. Brand matters much less than the competence of the person programming the hearing aid. Just the same way that a talented pianist could sit down at, any piano and play something lovely. But I could not do anything meaningful on a Steinway. It matters much, much more the skill of the person doing the actual task than whatever name it says on the side of the thing. So don't get hung up on, I have a Starkey, or I have a Resound, or I have a Phonak. Just find someone you like, find someone you trust, find someone that does best practices. So thank you. I'm I think doing okay on time. I guess that dragged on a little bit. Being concise is not something I'm typically very good at. So let's see about the questions here. Okay. All right, I'm gonna answer these in the order that I saw them. So let's see here. Somebody asked, from an engineering standpoint, it seems that an all in the ear device must be trickier to make work well and less likely to be satisfying than a behind the ear microphone device, because the former will have inherent feedback problems. Is that true? So excellent question. Let's talk about feedback. Feedback is the whistling or squealing that hearing aids tend to produce, and it used to be a much bigger problem than it is now because the algorithms that work to reduce it have gotten better. What causes it? Well, you could think of a hearing aid very simply as a speaker producing sound and a microphone picking up sound. If the speaker produces a sound that gets back into the microphone, then the microphone will amplify the sound, pass it onto the speaker, which will pass it onto the microphone, which will pass it onto the speaker, and you get this horrible sound. The reason that does not happen all the time is that the speaker and the microphone are usually separated. So in the behind the ear hearing aid, the microphones are going to be in the part behind the ear and the speakers in the part in the ear. And we'll use some sort of a little rubber dome to kind of further separate the two. In an in-the-ear hearing aid, it's true that the two are physically closer together, but what matters less than the actual proximity is the degree of venting. So at risk of getting a little bit technical here, in-the-ear hearing aids will typically have some sort of hole in them secondary to where the sound comes out. We call it a vent, and that hole will run all the way through. And the reason we'll do that is if you plug your ears, you're going to notice that your voice sounds really weird. And if your ears are totally plugged, people say, oh, it sounds like I'm talking in a barrel, or it sounds very hollow and weird. So the vent kind of alleviates some of that perception. The more open a fitting, the more vented a fitting, the more you risk feedback, but the more natural the sound quality. So it depends on the person's hearing loss. A more powerful hearing aid runs a higher risk of feedback. So these are all factors that we're looking into when we're picking a hearing aid for someone. But to answer the question directly, I would not say that in-the-ear hearing aids are inherently more prone to feedback than behind-the-ear hearing aids, even though I logically see that makes sense. But the feedback reduction algorithms that are designed to sort of catch feedback as it's occurring and then stop it in its tracks have gotten so much better over the years that this is usually a non-issue. If feedback happens, it's usually related to a bunch of wax in the ear, poor fit physically of the hearing aid, or some sort of programming problem. Okay, somebody said, what do you know about, two people said things about Costco hearing aids. Okay, excellent. So I have a whole sort of variety of opinions about Costco. Oh yes, let me stop this screen share, somebody asked. Okay, perfect. Okay, very good. All righty. Somebody asked about Costco hearing aids. There's two types of Costco hearing aids. There are Kirkland signature hearing aids, which are the Costco branded ones. And just like all Kirkland signature products, the way that works is they sort of go to different companies year after year, and they'll sign a contract to, create, however many tens of thousands of sales. Let's talk about Costco in general, and then we can talk about Kirkland versus name brand. I love Costco as an institution. I think Costco, from a audiologic standpoint, is kind of a mixed bag. From what I've heard from patients, it really depends on who you get. Some people at Costco are going to be fantastic. The actual hearing aids they have, for the most part, are great. So the technology is good. Like I said, though, the person programming the hearing aids matters a lot more. And to Costco's credit, they love to hire from within, which politically I'm 100% there for. It does mean that you might have someone with less experience because they might have been doing some other task at Costco before they started doing this. There's also going to be perhaps a higher share of hearing aid dispensers, but that's not necessarily a bad thing. There are sort of two types of professionals that do what I do. There are audiologists like myself who have a doctorate degree and go to school for a long time. And there are hearing aid dispensers where the requirements vary state by state, but usually you just take a test and have a high school diploma. And that is not to say that all audiologists are good and all dispensers are bad. I think that nothing could be further from the truth. There are fantastic providers in both categories and probably lousy ones too. What I'd simply say is at Costco, it's just a little bit more, it might be harder to tell who exactly you're going to get beforehand. I've had plenty of patients come to my office that said, you know what, Max, I went to Costco and I just had a horrible experience. And these are usually people with sort of non-traditional hearing losses, people with asymmetric hearing losses or a history of surgery or some other complicated situation. So working at an ENT clinic, I see a lot. My bread and butter, what I do all day is people with weird hearing, forgive the expression. However, there's a whole lot of people out there that just get a little older, Their high frequencies get a little worse. And for a lot of those people, I think going to Costco probably could be a good thing. The best thing is to just, again, make sure that you like the person and that you take advantage of that return period if you don't like the service you're getting. I think that's probably what I can say about that. In terms of Kirkland Signature versus general name brand hearing aids at Costco, I would be very careful with the Kirkland Signature ones because they are locked. So hearing aids are little programmable, custom programmable computers. And so let's say somebody comes to, actually, and I just got a question about this too. How about buy Costco high end and then go to good audiologist to go from there? So this is a very good question. And a lot of people, people have tried this. And what happens is this: if you buy the name brand hearing aid, you can go to Costco and get the name brand hearing aid and bring it to me. And I'll say, yes, I'd love to work with you. Obviously, we'll have to charge you for my time. So we charge an adoption fee because we didn't make any money on the sale of the device, but I'm happy to do so. But if they got the Kirkland Signature brand, or if this also applies if they went to like Miracle Air or somewhere, those hearing aids are locked. I cannot connect those hearing aids to my computer and reprogram them. So I'm unable to, my hands are tied. I cannot connect them to the computer. That's at least the case with the current generation. I don't know if that is a design feature going forward in all of them, but yes, be careful about the Kirkland Signature ones if you plan on going somewhere else. Does that answer your question to the Costco people? Okay. But yeah, big fan of the organization. Love the way they treat their workers. Love the hot dogs. But I would say, whether that's where you go to get your hearing health care is going to depend on it. Different amounts of money mean different things to different people. And so Costco is going to have cheaper hearing aids because actually Costco sells hearing aids to patients cheaper than my clinic buys the hearing aids from the manufacturer. So we'll never be able to compete with them in terms of just raw price. So we have to just compete on services. And I know that I don't lose any sleep over it because there is always going to be people out there with all sorts of crazy hearing needs. And maybe if you have more unusual hearing loss, I'd be extra skeptical of it. But hey, if you go to your audiologist and you have a mild high frequency hearing loss or whatever, yeah, go for it. And tell me how it goes. I'd love to hear about it. All right. Somebody said, have you seen the technology change quickly in recent years? And do you think the changes will continue to show up quickly over the next decade? So I finished my undergraduate degree in 2013 and then started working in private practice in California as a hearing aid dispenser trainee to see if this was what I wanted to do, because my undergraduate was in neuroscience. So this was a pivot. And so I've been doing this for like 8 years now, almost, I guess 9 years. And in that time, the biggest changes I've seen from a quality of life standpoint are rechargeability and Bluetooth. Those both came on the market gradually with some devices that introduced them. They were kind of flaky at first, and then more devices introduced them. They got better, and now they're standard. Those are the sort of like best things to happen to hearing aids in the last 9 years. In terms of what's next, I think that we will continue to see artificial intelligence used in hearing aids to process sound better. Some companies are starting to do that right now. I think it's more marketing buzz than actual, help. Nothing against those companies. But yeah, so I think the sound processing will continue to improve. Hearing aids are always trying to improve speech recognition in noise. And fortunately, there's a lot of research dollars going into this because Amazon and Facebook and Apple, all these people are always trying to do speech recognition. And so all of that research will percolate from big tech into hearing aids, which are a relatively much smaller industry. And that will only benefit you all. But the research happens slowly and it translates to the clinic slowly. So I think that over the counter will be a big logistical change. But in terms of the technology, I think I don't see any paradigm shifts right around the corner. We still need to deliver sound to the ear canal. There are things like regenerative medicine for hair cell regrowth and things like that. These are long research pipelines and still very much in the early days. So I think that it's possible that you'll see headlines in the next few years about hair cell regrowth. For instance, birds can regrow the hair cells in their ears. We cannot, but we can regrow cells in our intestines. Why is that? How can we make our ears like our intestines? People are working on that. So that's sort of a non-technological bit of research. going on. And then there is also a whole bunch of other types of devices that I didn't even go into. Cochlear implants are getting better all the time. They were recently approved, semi-recently approved for single-sided deafness. So now you can have very poor hearing on just one side and get a cochlear implant. Surgeons are also getting better at preserving hearing when they do cochlear implants, and so they don't completely wipe out what you've got. All right, I'll stop rambling because someone else had another question here. High frequency loss and audiogram you showed, but loss getting worse at mid-range. So reprogram is better at high-end aid. High frequency loss and audiogram you showed, but loss getting worse at mid-range. So reprogram is better at high-end aid. I'm not sure I fully understand the question, to be perfectly honest. I will tell you that the typical pattern is you'll lose the high frequencies first, maybe down to like 70 decibels or so, or thereabouts. And then your mid frequencies, you're going to start falling off. If you already have hearing aids, they can be reprogrammed as this happens. So let's say you guys go to this talk and you're like, oh, this was great. Dr. Max told me I should get hearing aids. And you go and get hearing aids. And then 3 years from now, your hearing is worse. And you're like, well, shoot, I don't want to spend another $4,000. I want to just use these ones. They've been working great. Go to your audiologist and they can reprogram them. My clinic, we include visits for 3 years. So if it's been a longer time than that, then there might be some sort of charge. But like, for instance, I would charge someone $140 to reprogram a hearing aid that they bought from me, but say 5 years ago. So you're looking still at much less than the cost of a new hearing aid. Somebody said, I understand rechargeable advance, but not Bluetooth. Please explain further. I'd be happy to. There are 2 ways in which Bluetooth technology has impacted the hearing aid world. One of them is the availability of apps to more easily control your hearing aids. So hearing aids are fairly automatic these days. It used to be the case that hearing aids, you'd have a church program and a restaurant program and a crowd program, and you'd press a button over and over again, and it would cycle through these different modes. Maybe you'd have a volume control too. Now the hearing aid is doing this for you most of the time. But when you do want to make a change, you're not usually going to do it these days with buttons, although you can. Usually people would rather use their smartphone because then they can see what they're doing, adjust volume up and down, adjust some parameters like bass and treble. And there are certain brands of hearing aids that have a Find My Hearing Aid feature. So if you ignore what I said about masks and get a behind the ear one because they look cool, and then you fling it off with the mask and you leave the restaurant and you can't remember where it was, you can take your phone out and you can kind of track it and you can see where it last saw your hearing aid. So that's a handy feature. The other thing that the Bluetooth stuff does is it will allow you to stream audio to your hearing aids. The audio that most people are going to want to stream is phone calls. So let's say you're having a phone call. Instead of just holding the phone up to one ear and hearing that, you're now going to get it in both ears. That's the biggest help, in my opinion. That's where Bluetooth is worth all the pain in the rear. And it is a bit of a pain. For instance, Apple released a new operating system like last week, iOS 15.4, and it unpaired all Bluetooth hearing aids from everybody. So if you guys have friends with Bluetooth hearing aids, they probably were just like, oh, what happened? But then this week they released 15.4.1 and now it's better again, but I think you have to repair them. So whenever that happens, it just sends a ripple of page. There's just dozens of people now that are like booking out and trying to get help repairing it. That is the type of stuff you have to contend with Bluetooth. So if you're tech savvy, no problem. If not, there are resources and your audiologist will often help. But yeah, Bluetooth is a bit of a pain, but it can really be helpful in terms of phone calls. And you can also stream whatever you want. You could be walking around listening to NPR. You could be walking around listening to Spotify, So the music, just because the sound quality isn't as good as dedicated headphones, doesn't mean it's not going to work. Someone said, talk more about differentiating among audiologists that consumers can determine. This is hard. I would say, so I've worked in Philly. I worked at Jefferson for a year and it was great. I love the folks there. I also know I've seen Penn's program and it looks top notch. I would say that at either of those facilities, you're probably going to be in pretty good hands. There are also all these different private practices and ENT groups, and I certainly don't have familiarity with all of them, nor am I the sole authority on, you know, who is a good audiologist. I think part of it is the relationship. Part of it, like I said, you can use asking if they use relay or verification as kind of that litmus test. I think also, you know, it depends on what you consider to be a good audiologist. So for instance, for me, it was important to find a clinic where I was not paid a commission based on the level of technology people get. So I make the same amount of money at the end of the year if you get a $6,000 hearing aid or $3,000 hearing aid. So I have no financial incentive to sell you one versus the other. So you can ask your audiologist, do you work on commission? And if they do, that doesn't necessarily mean they're a bad audiologist. You should just understand that going in, because there's plenty of evidence that hearing aids work. There's less evidence that $6,000 hearing aids work better than $3,000 hearing aids. There's some evidence, but it's of much lower quality. So, you know, you can ask if they work in commission. You can ask if they, you know, do relay or verification. And then other than that, you know, get some word of mouth referrals. Find someone who's happy with their audiologist and see where they go. I mean, I drive an hour plus to work every day, so I bet you guys can find someone in the Philly area. I bet that's good. Somebody says, can you purchase hearing aids at Penn or Jeff, or did they just do the testing? I know that at least Jefferson does hearing aids. I bet Penn does as well. Okay. Somebody said, I'm a likely candidate for cochlear implant, having had an attack of sudden hearing loss on one side and being a musician. Can you explain, I'm a techie, what you're referring to by preserves your, oh, and at Jefferson, you know, Dr. Sadeloff, he's my guy, great for musicians. I don't know him. It's been a few years since I worked there, so that ENT might be newer to the practice. I remember Doctors Wilcox and Fitzgerald and Cognetti and some of the ENTs there, but I don't, it's a big enough hospital. There's definitely folks there that, and there's also different offices. So there might be satellite locations that I don't know. Okay, so there's lots unpacked here. So first of all, I'm so sorry that you experienced a sudden loss of hearing. That can be really devastating, and it's hard because you go from, you know, you have such a good point of comparison. You've got good hearing and suddenly it's terrible. Not only that, but you've got good hearing in one ear and then maybe poor hearing in the other side. So these are patients, some of whom are really, really distraught because they're not like many people who come in for whom they have decades to contend with this problem. For sudden hearing loss, it's challenging. If you are a cochlear implant candidate, you will have a comprehensive workup that's going to determine exactly how well you hear. And that's the most, really a cochlear implant workup is basically the most comprehensive hearing test possible. They're going to do all sorts of hearing tests, including probably some hearing tests in noise, which is not something we normally can do as much because there's no insurance reimbursement for it and there's no time anywhere in the world. So you'll have a bunch of tests done. And what happens is, if you remember back to one of my earlier slides, I had that pretty picture of the cochlea, and it was a little spiral. Well, different parts of the cochlea have hair cells that correspond to different frequencies. And the parts corresponding to the higher frequencies are near the base of that spiral, and the parts corresponding to the lower frequencies are near the top, or the apex of the cochlea. So if you put the way cochlear implants work is the surgeon sticks a little electrified noodle in your ear. They stick a little wire in the cochlea, very, very small. So the whole cochlea is like the size of a pea. They're going to stick a little wire in the base of that cochlea and try and curl it around the bend. And the farther in they push it, what's basically happening is you can imagine 15,000 little hair cells in a space the size of a pea, and then some human hand trying to stick a wire in there. Well, what happens? You've already got a bunch of damaged cells, but you're probably going to do some more damage on the way in. So cochlear implants typically result in some further decrease of hearing. So that's why classically cochlear implants were only for folks with really severe to profound hearing losses, but that has gotten better. They'll do things like dipping the electrode in steroids, or giving the, there's all sorts of things, or just doing a shorter electrode, or just putting it in just a different part of the cochlea. So there's all these different surgical techniques. And this is one of the things that I would research when I was at Vanderbilt. And there's a lot of different ways to preserve one's hearing. And by preserve one's hearing, I just mean damage it less by sticking the cochlear implant in. Oh, and you said the sudden hearing loss resulted from not getting steroids immediately. I had no idea. No one else had any idea either. You're not alone. It's not your fault. This is an area where there's extremely poor awareness. And that's why I'm kind of slamming this message into you guys' face. So I'm sorry that this talk wasn't a year ago. But you're in good hands. There's a lot of good care in the Philly area. So good luck. All right. And I should probably wrap it up in a little while here because I have to tend to my wife. Luckily, baby Milo has been asleep. But are there maybe like one or two more questions anyone had? And thank you guys also so much for your time. It's great to spend this evening with you guys.